Bismillahir Rahmanir Rahim. It gave me a great pleasure to share with you the first line management of metastatic HER2 positive breast cancer with case presentation. This is a 50-year-old lady presented with large left breast mass on January 2019. As we can see from this mammogram that the patient has a large mass with microcalcification at the inner quadrant of the left breast. This is also from a CT scan cut. A true cut biopsy and histopathology done, and it showed invasive ductal carcinoma grade 3 with the hormone negative, less than 1% ER/PR, while for the HER2 positive overexpressed +3. Staging workup revealed that the patient had multiple liver deposit and a sclerotic lesion within T9 and D12 vertebral body. Based on the NCCN guidelines, the patient was started on the triplet therapy, pertuzumab, trastuzumab, docetaxel. This is as category 1 recommendation. In July 2019, with follow-up CT scan after 4 months or 5 months of the treatment showed moderate regression of the previously seen hepatic focal lesion with remaining faint area with no enhancement on the IV contrast. November 2020, after 2 years of the treatment, the patient maintaining good performance status and echo was normal, CT scan small faint right hepatic focal lesion. So this is the Cleopatra trial, which abbreviation for clinical evaluation of the pertuzumab and trastuzumab. It is phase 3 trial established the role of Perjeta, Herceptin plus chemo as standard of the first line HER2 breast positive metastatic breast cancer. The rationale for this combination, as we know from the doublet therapy, that 50% progress within 12 months. And we know that pertuzumab and trastuzumab, they have complementary mechanisms of action. And from the phase 2 trials also, it had shown that the improved activity and a good safety profile with the combination. And we know the schemata of this trial, which recruited almost 808 patients, HER2 positive, centrally confirmed, to either doublet Herceptin docetaxel or triplet pertuzumab, trastuzumab, docetaxel. And the primary endpoint, progression-free survival by independent review, secondary endpoint, overall survival, progression-free survival by investigator assessment, overall response rate, and safety. And the treatment was given till disease progression. The eligibility criteria, as we mentioned, centrally confirmed HER2 positive, metastatic or unresectable, ejection fraction 50% or more at baseline by echo, no more than 1 prior hormone regimen for metastatic breast cancer, and the neoadjuvant or adjuvant systemic therapy, including trastuzumab and or taxanes, allowed if followed by disease-free interval 12 months or more. And should be no history of congestive heart failure or left ventricular ejection fraction decline to less than 50% during or after prior trastuzumab. We have similar baseline characteristic across both arms, and about the results will incorporate the data presented in the final data of the study presented in ASCO 2019 that showed the end of study analysis in metastatic breast cancer and confirmed 37% of the patient in the triplet arm, they are alive at 8 years. We know that the overall survival almost we achieved 15.7 months absolute period, which is if you compare the triplet 57.1 months in comparison with doublet 40.8 months, with hazard ratio of 0.69, and we know that 8-year overall survival rate 37% for the triplet in comparison with the 23% for the doublet. And there is consistent overall survival benefit in favor of the triplet across all the subcategories, including those who received whatever the neoadjuvant or adjuvant therapy, region, age group, race, disease type, estrogen, progesterone, or HER2 status. And when it comes to the progression-free survival, we have almost 6.1 month gain. We can say with the hazard ratio of 0.69, and at 8 years, we have progression-free survival patient 16% in the triplet in comparison with the 10% in the doublet. And there is consistent progression-free survival overall. That's all subcategories, again, regardless of the prior treatment, region, age group, race, disease type, hormone status, and HER2 status, either by FISH or immunohistochemistry. What about the response rate? Clearly, we can see that we have 70% for the doublet, and for the triplet, we have 80% with significant p-value 0.001. And for the withdrawal from the treatment, higher rate among the doublet, 70%, while in the triplet, only 57%. The all grades side effect, which showed more than 25% incidence or more than 5% difference between the arms, we can see that we have for the triplet, pertuzumab mostly related, more diarrhea, more rash, more mucositis, and febrile neutropenia with the dry skin. While for the doublet, we have more peripheral edema and constipation. For grade 3 or more adverse event with incidence more than 2%, we have neutropenia a little bit higher in the triplet, which is around 48%, while 45% in the doublet. Febrile neutropenia double almost, 13.8 in the triplet, 7.6 in the doublet. Diarrhea, 5% in the doublet, 8% in the triplet, while slight higher leukopenia in the doublet. The most important issue is the cardiac side effect. We can see that surprisingly that those patients with the doublet, they have 6.6% LV, higher LV function decline to less than 50% in comparison with 3.8 only in the triplet arm. And causes of death, we can see that we have higher death due to disease progression among the control, 80%, while 14% in the pertuzumab, and similar death, while for the death due to adverse effect, it is almost comparable between the two arms, 2.5 in both arms. And infection were the most common cause of death. So the conclusion of this trial that the final analysis shows that the previously observed improvement in overall survival with triplet versus doublet were maintained after a median of more than 8 years of the follow-up. The long-term safety and cardiac safety profiles of the triplet were maintained in the overall safety population and within crossover patient. The dual blockade therapy demonstrating an 8-year landmark overall survival rate of 37%. And thank you.